Great, good afternoon, everyone. This is Dana Harganani, Chief Medical Officer for the Oregon Health Authority. I am joined by Dr. Tom Jean, our state deputy epidemiologist and deputy public health officer, sorry. It's only Tuesday, and Dr. Smith, our medical director for the Health Evidence Review Commission, all of us working on the COVID-19 response. Thanks for joining us again. Today is Tuesday, May 19th, and as usual, we're going to walk through our webinar and slides for you. Many of the details we bring to you today are in response to questions we've received or new information that we wanted to make sure you were aware of. Please do submit your questions online during this webinar in the chat box. We always capture them at the end and base our next webinar on the questions you've sent us. And we'll share again at the end of the slide an email address you can send any questions you have after. So we will go ahead and get started. Today we're going to provide you our regular EPI updates. We're going to give just a very brief update on reopening Oregon. I'm going to speak briefly about remdesivir, an antiviral drug. We will share just a brief update on what's happening on the pediatric multisystem inflammatory syndrome, which we started sharing with you about a week ago. And then we'll dive in deeper into antibody and antigen testing and close with some questions that we'd like to answer for you. So this data is as of yesterday. These are our cumulative counts of test results in Oregon. As of yesterday, we had just over 3,600 positive tests or COVID cases. We have had a total now of 138 deaths as of yesterday, unfortunately. And as you can see, a growing number of negative tests. As you know, these test results do not all account for both presumptive cases that we're aware of, as well as other cases that we know exist but have not been tested, especially originally when we were only testing the most severe cases of symptoms. I'm going to pass it off to Dr. Jean to take a look at our testing results over time.
Thanks. So here's our table showing weekly testing results, including the counts for positive tests, the total number of tests done each week, and the test positivity rate. So if you look at the second to right column, that is last week's, the most recent results. The positive tests, the confirmed cases that week declined a bit from the previous week, 438. You can see we've had a continued increase in our total tests each week. So from 9,000 about a month ago now to almost 17,000 total tests done last week. So that's great. And then finally, the test positivity rate continues to decline. Last week was only 2.6% of all tests were positive. And then our cumulative test rate is 3.9% now, much lower than the national average of 15%. Here's our epi curve. Pretty flat plateau here in total cases over the past few weeks, but with the decline in the blue bars, which are the hospitalized cases. Daily ED visits clearly uptrending for the past month and a half, almost 2 months, but pretty gradual. And you can see that COVID visits here are not even registering in the total visits. On the next slide, we see the daily visits for COVID-like illness continue to decline and currently below 1%. So that's reassuring. This is the latest based on cumulative cases, risk factors. You can see that despite our relatively high proportion of deaths that are related to congregate living, the total number of cases is still a minority, 20% versus 64%. And again, the gray bars in the middle are the unknowns. We don't have complete information when we do case investigations. We don't always get answers to all the questions. A minority are healthcare workers, and a very small minority are were connected with travel outside their home area. And then there are quite a lot, the majority had underlying conditions.
Just to note for all of you that this is part of our weekly report and the following slides to come. These are updated weekly on Tuesdays usually, so apologies that we didn't get the most updated report. This is from a week ago, so please do check out our website for the weekly report later today or tomorrow, and you'll see the most recent data.
A few more tables here from our weekly report. This is showing the severity and the cases by age group. So if you look at the percentage, the third column from the left there, pretty even distribution, or at least an expected distribution, with a lot of cases in the adult kind of middle age ranges, where most of the population is, and then pretty low in kids. And that's of course based on case reporting. The actual rate of COVID-19 in children may not be any lower, it may even be higher, but they tend to have milder illness, and they're less likely to get tested. And then in terms of the case fatality rate, you see a starkly different picture there, with a much higher case fatality rate in people over age 60, especially those over age 80. And also hospitalization is commensurate with that. Severity by race. So in terms of the disparities here, I guess I'd highlight the cases per 10,000, and you'll see that Blacks, American Indians, Alaska Natives, and Pacific Islanders all have a much higher case rate per 10,000. The good news is, though, the case fatality rate is there aren't major disparities there. Blacks do have a slightly higher than whites. But otherwise they're all below, and all pretty similar in the same order of magnitude. And then the next slide is showing ethnicity, Hispanic versus non-Hispanic, or Latino, non-Latino. And there's a big contrast here in terms of the case rate per 10,000, 18 per 10,000 for Hispanic versus 5.2 for non-Hispanic. And then the case fatality rate is actually quite low for Hispanics, 1.1% versus 5.4% for non-Hispanic. Part of that, again, probably due to age distribution.
We're looking again at our COVID hospitalizations that are reported daily from our hospitals across the state. This is actually data from this morning, and it shows that across our Oregon hospitals, we currently have 61 COVID positive patients hospitalized. Of those, 24 are being cared for in intensive care unit, and half of those are being ventilated mechanically. On the left side, you'll see these are the numbers of patients with either suspected or confirmed. So a large number of still suspected patients in the hospital, ICU, and on ventilators. As you might expect, people flow in and out of this column. If they have a test pending, if it's positive, they'll move over to the right column in the next data capture. If they're negative, they will drop off there. So this is quite a fluid number, particularly on the left-hand side. The next slides are trend graphs of hospitalizations, and I just want to note that these were updated as of yesterday. Unlike the data I just showed you on the slide, these are old as of yesterday, and today we did have an uptick in hospitalized COVID patients, a slight one, but we may be able to see that on the trend graph differently as I get these trend graphs updated. So here is the trending for COVID hospitalizations for both confirmed and suspected cases. Again, you can see on the bottom those who were in the ICU and of those who were requiring mechanical ventilation. And then here are the trend graphs for those patients who were known positive cases based on testing. And again, you can see a significant decline since about 5 or 6 weeks ago. Perhaps some plateauing. We'll continue to look at this data quite closely. Okay, just briefly want to talk about reopening. We did share a fair amount of this last week. We're not going to continue to share this ongoing, except for, I guess, news to share with you. There is a tremendous amount of information on our website about reopening, including criteria, timelines, and all sorts of guidance for different sectors on what would be expected in terms of ensuring physical distancing and appropriate PPE use or facial coverings depending on the actual sector. So we really invite you to visit that site for all the updated information. I mentioned to you last week, this slide here, that there were some statewide changes that have occurred that could be captured under the reopening term. We've talked a lot about elective procedures, which we're able to resume at a lower volume as early as May 1st if certain criteria were met. On May 5th, the governor announced some opening of some recreational sites. Not all recreation sites are open, and it's really important to check and still being requested that there not be travel broadly outside of your hometown or home area, which we'll talk to a little bit later. But there are definitely more recreational areas open, especially where physical distancing can be followed. And then on May 15th, additional statewide changes to allow opening of some retail stores as listed here, and some new guidance available now, particularly around youth programs, et cetera. And we can bring more of those particular details to you in the future. We did also talk about that the governor was receiving applications for phase 1 reopening as of about a week and a half ago, and the governor announced those decisions last Thursday at a press conference. Just to remind you, phase 1, when the counties are allowed to move into phase 1, it allows for some increased sizes in local gatherings of up to 25 people while still maintaining physical distancing, some new allowances for restaurant and bars, and as well personal services, for example. And applications were received by all counties except Clackamas, Multnomah, and Washington counties for phase 1. And of the applications received, Marion and Polk County applications have not been approved yet due to particularly around case counts and criteria related to that. You can find all the applications and the criteria again on our website. All the other 31 counties outside of the 5 I just listed before have been approved for reopening as early as May 15th. I believe some counties were making choices on when they would fully open, but I suspect that most of them have been by now. So again, here's our website. If you visit the Oregon Reopening tab, you can find all sorts of information about criteria, the applications, et cetera. There's also a specific tab that can show you the reopening criteria with some up-to-date information about what criteria counties are meeting. So please welcome you to go check all of that out. Moving on, we're going to talk briefly about remdesivir. So fairly short notice, last week, the Oregon Health Authority received allotments from the federal government of remdesivir. So remdesivir is an experimental drug for the treatment of COVID-19. It's a direct-acting antiviral that inhibits viral RNA synthesis. It is still an investigational drug. It does not have a full FDA approval for any indication. It has been studied for a number of years now for the treatment of various different viral illnesses, including things like MERS and Ebola. And all of that information on remdesivir and the prior studies that have been done can be found on FDA's clinical trial site, or NIH, excuse me. However, there have been ongoing studies since January, I believe, of remdesivir for the treatment of COVID-19. And on May 1st, the FDA announced that it issued an emergency use authorization to permit the emergency use of remdesivir for COVID-19, particularly in face of no other specific treatments having been approved for COVID-19 at this time. So a little bit of background, again, there have been several studies involving remdesivir. The NIH released a news and preliminary results for a study with remdesivir treating COVID-19 patients with advanced lung disease. The preliminary results from that study, as reported, show that patients who received remdesivir had a 31% faster time to recover than those who received placebo, and that was clinically significant. The median time to recovery was 11 days for patients treated with remdesivir compared to 15 days with those who received placebo. The differences in mortality rate were not statistically significant, and they ultimately did make the decision to move the placebo arm to receive treatment of remdesivir after they reviewed these preliminary results. So that the mortality outcome, I do not believe, is going to be something that we will see further results on. And the full set of the data from these studies have not been published yet. However, again, this information was produced and available online. You can find more information about this particular study for remdesivir as I've listed here on the website. So based on that study and other emerging data, FDA issued the emergency use authorization, which allows the use of remdesivir during this emergency for the treatment of patients who have suspected or laboratory confirmed SARS-CoV-2, and they have to be considered severe and to meet the EUA requirements. So that includes the patients have to be hospitalized. This is an intravenous drug treatment, so they have to be in a hospitalized situation. And they have to meet the criteria set forth by the FDA under the emergency use authorization as having severe disease. So those are listed here. So low oxygen saturation, requiring supplemental oxygen, and or requiring mechanical ventilation or ECMO. So based on the distribution we received last week, we did some very fast work to put together our criteria and our distribution plan for remdesivir. Starting Sunday, we began distributing remdesivir to hospitals upon notification to OHA that the hospital has an eligible patient and that they've signed an agreement outlining certain steps they will take and information they will share with us about any patients that they are to treat. At this point, we believe that the remdesivir doses that we've received as a state are adequate to treat all of the patients that would meet the clinical criteria based on the number of hospitalized patients that we currently have. In addition, we have 4 sites in Oregon who are currently participating in other clinical trials for remdesivir. So their patients are already receiving or have options to be enrolled into a remdesivir trial. And also will state that for pregnant and pediatric patients, remdesivir is accessible through the manufacturer through compassionate use criteria. So remdesivir, again, we began distributing to hospitals based on our distribution plan and criteria. We are neither recommending or discouraging the use of remdesivir given that it is experimental and we don't have full outcome data both from efficacy or side effects. But according to the EUA, are delivering it to hospitals who desire to, through shared decision making with patients, decide to move forward with this treatment. Ultimately, there's 2 courses, a 10-day and a 5-day course. We won't go into details about that, but we are sending out the 10-day course for considered use, and hospitals will treat according to appropriate decisions by their clinician team. I just heard that we are also expecting a 3rd shipment any day now. So again, at this point, we believe that we have adequate remdesivir to treat our currently hospitalized patients. We are not planning to hold any back at this time. If and when we begin to experience this as being a scarce resource, we will revisit how we are planning our distribution for this EUA approved drug. I would again direct you to our website if you're curious. Most all of us working in an outpatient setting will not be coming into access to remdesivir because its EUA authorized use is for hospital settings and severe patients only. But should you want more information, all of these are linked to our website where we have all of this information posted, including FDA fact sheets for both patients and providers if you're curious and want more information about remdesivir. All right, I'm going to pass to Dr. Smits for an update on pediatric multisystem inflammatory syndrome.
Thanks, Nina. So we discussed this on our call last week. What I wanted to do this week was call out that the CDC has released a case definition. It's very similar to kind of what we looked at last week. So the CDC case definition is any child less than 21 who presents with a fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization with multisystem issues without another plausible diagnosis, who test positive either by PCR or antigen test or had a COVID exposure within the past 4 weeks to the onset of symptoms, so somehow related to COVID. Can you go to the next slide? So these are just the slide before you noticed there was a couple of little comments. They just define what they include as a fever, and then they define what they include as inflammatory markers. And they do note that some of these patients actually meet criteria for Kawasaki disease, but they should still be reported as a possible pediatric multisystem inflammatory syndrome case if they meet the case definition. And health providers as well as public health should consider the pediatric multisystem inflammatory syndrome in any pediatric death with evidence of SARS-CoV-2 infection. And then just the last couple comments, the CDC notes that this is a pediatric syndrome, but we actually don't know if it may actually occur in people over 21. If you have an older patient who seems to meet the criteria that the CDC laid out, please still report that to OHA or to your local health authority. We don't know how to treat it yet. We don't know the pathogenesis, clinical course, etc. So all of that is still up in the air. We did have one reported case in Oregon, and you can see the press release information link on the slide there. OHA is working on coming up with our own case definition based on the CDC. We'll have that out very shortly, and then we are going to request that providers report this to their local health authority or the Oregon Health Authority if you have a suspected case.
Great. Dr. Jean.
Yeah, so I'd like to provide an update on testing, especially antibody testing. I know there's been a lot of interest in that. So we'll talk about that and also some other testing issues that are timely. So antibody testing is also known as serology testing. So it's basically a blood test that looks for antibodies. It is increasingly available. As of today, we now have 12 different tests, serology tests that have received the FDA emergency use authorization. And so I just wanted to highlight some key points here. First of all, we recommend against using any COVID-19 test of any sort, including PCR, that doesn't have the FDA EUA. The EUA is a very basic kind of independent oversight of a test. So because of these unprecedented times, the FDA allowed basically any company to market tests, even if they haven't received an EUA. And to be clear, an EUA is not even the same thing as FDA approval. It's a very limited, vetting of a test by the FDA. It's not a full FDA approval process. So do not recommend anybody use any tests unless it has that EUA. There's a list here with this link of all the tests that have FDA EUA, including molecular tests and serology tests. And then our big recommendation here is that antibody testing is not recommended for diagnosis or exclusion of COVID-19. And the reason for that is it really is about 2 weeks after symptom onset until an antibody test is reliably positive, because that's how long it takes for the antibodies to develop. So at that point, it's just really not useful to diagnose an illness in most cases. So when you're using antibody testing, if you decide to use it, you need to be aware and notify your patients of the limitations to antibody testing. So that first thing I just mentioned about not being good for diagnosis is a key point, but we also still don't know the extent to which antibodies may confer full immunity or partial immunity to COVID-19, or for how long. There is more data coming out on that all the time. It's still not anywhere near conclusive. And then there is potential for cross-reactivity with other coronaviruses. Most of the antibody tests I've looked at have showed minimal to no cross-reactivity, but it's certainly possible, and I haven't personally reviewed all 12 of these tests in detail. And again, the EUA is not the same as FDA approval, so that's a limitation there for any of the COVID tests. Next slide. So we do track all lab reports from all COVID-19 tests, including serology tests. However, positive serology tests are not categorized as confirmed or presumptive cases, and they're not reported in our case counts. They become a suspect case, which is really kind of an epidemiologic, for our own tracking. It's kind of the lowest level of what we'd call a case, and it's arguably not even a case. So we don't follow up on positive serology. If resources allow, the local public health authority might call a provider to ask if molecular testing was also done to make sure we've gotten that result, and maybe to find out a little bit more about why serology testing was done. So again, from a clinical perspective, there's not a lot of utility for serology testing, in the setting of our lack of understanding of immunity. And then there's another link here to an FDA comparison that shows selected antibody test performance. So I'd encourage you to check that out. And I've actually, in the next couple slides, I've got a couple of highlights from that. So they've got maybe about 8 or 10 of the most recent antibody tests on their website here. And the nice thing about it is they've put a little table for each test, and they show the sensitivity, the specificity, as well as the positive and negative predictive value. So I wanted to talk through this just so everybody understands some of the issues. So the first antibody test that was got the EUA was from Celex, and that's a rapid test. So one that is not a full LISA, it's kind of a rapid. I think it can be done point of care. And these tend to be a little bit less reliable. So you can see the numbers are pretty good for sensitivity and specificity in the 90s, 94% about, and 96% specificity. So that sounds pretty good, but if you assume the population prevalence of exposure to COVID-19 of only 5%, and in fact in Oregon it could even be lower than that, at a prevalence that low, the specificity becomes a real issue. And so a specificity of 96%, which sounds good, is actually low enough that you're going to get a lot of false positives. So the positive predictive value takes into account both the prevalence of the disease and the false positive rate. So you can see with a 96% specificity, you actually have a barely better than 50% positive predictive value. So that means if you get a positive result on your patient, it's kind of a coin toss as to whether it's a true positive or a false positive. So obviously that's not very useful. And the negative predictive value, of course, is quite good because the prevalence is low, and or we assume the prevalence is low, and the sensitivity is good. So the nice thing is if somebody is a negative, you're pretty confident with this test even that they're truly negative and they haven't been exposed. So the next slide, I'll show the numbers for a better test. And this is the Roche test, which is a high throughput ELISA test. And if you look at the numbers there, they've not only have they tested on a much better sample size, about 5,000 people for the specificity test. They've gotten really good results. So 99.8% specificity versus 96% for the other test. So with a specificity that high, you can see even with a low prevalence, the positive predictive value is quite good. So 96.5% positive predictive value. That means if you get a positive result on your patient, you're pretty sure that they're a true positive and there's not a high risk of false positive, less than 5%. So I just wanted to highlight that these are things we should be thinking about if you're going to go ahead and order an antibody test on somebody. and it's still subject to all the concerns and caveats I mentioned about what does a positive antibody test actually mean. Okay, moving on to the next slide. We had a question about antigen testing. There is now one antigen test with an FDA EUA. It's this Sophia 2 SARS antigen. And basically these antigen tests they're kind of similar to an antibody test, except instead of looking for an antibody, they're looking for part of the virus. So they're not PCR. They tend to be rapid tests. So results in minutes. They can be done point of care. And this particular test, it actually detects both the original SARS virus and SARS-CoV-2. That's not really a concern because I believe it's fair to say SARS-1 is extinct. It hasn't been reported since 2004. It probably exists in labs somewhere like smallpox, but if you get a positive on this test, we're not worried about deciding whether it was SARS-1 or SARS-2 because SARS-2 is what's circulating. So this is a test that uses nasal swabs. The performance data that I've looked at from the manufacturer, as typical, it was based on pretty small studies, showed a sensitivity of 80% compared to PCR and a specificity of 100%. And again, this is an antigen test. It's looking for the virus itself, but it does have a higher chance, a higher risk of false negatives compared to PCR. And that's kind of problematic. You'd really want the opposite. You'd want to, for this kind of test, you'd want a higher chance of false positives and a low chance of false negatives because most people are going to be negative, truly negative. So if you run this test on somebody and you get a negative result, because the sensitivity is only 80%, you're not that confident that it's a true negative. So ideally, you would run a second test. You'd run a PCR, but since most people are going to be negative anyway, what's the usefulness of the test if you have to run two tests? You might as well not do this test in the first place. So the benefits are it's a rapid test. It does have an EUA. It also did not show cross-reactivity. At this point, until we have more data or another test with better performance, I'm not sure it's really worth pursuing. And there was a question about availability. I think you'd have to contact the manufacturer. I suspect it is available. Probably not a huge shortage, but I'm not sure about that. So if you go to I forget the name of the company, it begins with a Q, but if you Google Sophia 2 antigen, you'll come to the company's website and find out information on how to order it. Okay. And then finally, I wanted to talk about the Abbott ID NOW test, and they've been in the news the past week because the FDA issued a press release on the 14th about some data suggesting inaccurate results. So this is basically a PCR test. It's not quite PCR. It's an isothermal nucleic acid amplification test. Rapid result. In Oregon, we received 15 Abbott ID NOW machines from the federal government, and we distributed those around the state to try to help with increasing testing capacity, especially in smaller, more rural areas and smaller hospitals. The concerns are there was a preprint study out of NYU that compared this ID NOW test with the Cepheid PCR test. And the FDA had also received some adverse events reports about inaccurate negative results. And then, sorry, I'll go back to the second bullet point there. The initial study from the manufacturer showed 100% sensitivity and specificity, but it was a very small sample with only 50 samples, and it was a contrived study with spike samples, so it wasn't actually clinical specimens. So they took known virus specimens and spiked them and compared the positive and negatives there. So let's go to the next slide. So part of the concern with this NYU study was the ID NOW missed about 1/3 of the positive samples when using NP swabs in viral transport medium, which is one of the things that you'd have to transport virus in a vial. And it missed over 48% of positive samples when using dry nasal swabs. Now, there have been other studies that showed a higher sensitivity, much higher sensitivity, but this is concerning. The FDA basically said negative results may need to be confirmed with a high sensitivity molecular test, which again gets the problem. If you're going to run this test and you're not confident in a negative result, why even run it? So we're reviewing the evidence because, again, this was a preprint study and there is other data out there, but we're going to try to get a better sense for how concerning this is and what the performance is. But I know that in addition to the machines we've distributed, there are some clinical labs or clinical sites that are using the ID NOW machine. So it will be important kind of to get a better sense for how inaccurate it may be. So that's just an update on ID NOW.
All right, we're going to turn it back over to Dr. Spitz to walk through some questions that we are responding to from you all.
So there were a couple questions from last week about how to tell a patient when they can leave isolation. So this is all on our website. You can find it if you want it in more detail. So if a patient has COVID-19 and they've home isolated, they can leave home. If they have not had another test to determine if they're still contagious, they can leave home if they have had no fever for 72 hours without any medications, and other symptoms have improved, no cough or shortness of breath, and at least 10 days have passed since their symptoms first appeared or since that positive test. If they did have a second test to determine if they were still contagious, they can leave home after 3 things have happened. They don't have a fever, their other symptoms have improved, and they have 2 negative tests in a row at least 24 hours apart.
Yeah, and I would just wanted to add to this that in general, most people who are at home probably wouldn't need to go in to get a second test or the 2 negative tests. And often that may end up delaying their release from isolation, because we know that the PCR can be positive even after those 10 days. And PCR positivity doesn't necessarily mean you have infectious virus. So the test-based strategy is mostly for people who are in the hospital or who are going to be discharged to a high-risk setting like long-term care facilities. But we know lots of people are interested in testing, and testing is increasingly available. So people on home isolation may end up with some of these repeat testing, but not necessarily recommended. The most important thing would be the 10 days after symptoms onset, and then no fever for 72 hours, improving symptoms.
And then this is for the asymptomatic patient. So they didn't have any symptoms, but they had a positive test. Perhaps they were going to have surgery or something like that, and they were asymptomatically tested. They can leave home isolation if they didn't have any other testing, but they've had 10 days passed since that positive test, and they continue to have no symptoms. If they did, as Dr. Jean was alluding to, if they did have an additional test to see if they were still contagious, they can leave after 2 negative tests 24 hours apart. And again, that probably would be before they were going to go into a more high-risk setting, perhaps. A few other questions that came across. There was a question about what kinds of things do we need to worry about for post-COVID care. It's a great question. There's no specific screening or follow-up currently recommended. Obviously, this is something that's going to be a quickly developing field as we've had more and more survivors. And we may find that there's some people who may have lasting issues, but hopefully they'll mostly have recovered entirely. The one thing that is a big concern, which is a little bit of a different question, is that a lot of these patients are going to be quite debilitated after a prolonged hospitalization, so they'll need skilled nursing facility or in-home post-support. I know that wasn't answering the specific question, but that's where the main policy questions are. If we do start hearing of any follow-up pulmonary tests or anything else that might be recommended by the CDC in the future, we'll definitely update you all. Another question that came around was, why do restaurants and bars have to close at 10 in the phase 1 counties? It's kind of a multi-part answer. This allows more cleaning, and also the later it gets in the evening, the harder it is to sort of enforce and maintain social distancing. So 10 p.m. was thought to be a good time frame for that. There was a question about the transmissibility of COVID-19 out of doors. The CDC notes that it's a lot lower risk of transmission out of doors compared to indoors. So definitely go outside, but maintain a 6-foot distance from others. This is probably sufficient even for higher risk people. If you're quite high risk, you may want to stay further than 6 feet or take other protective measures. And then there was a question about travel. The CDC is still recommending no non-essential travel within the U.S. Non-essential meaning you're not going to a funeral or some serious thing that you need to attend. And the governor is still ordering non-essential no non-essential travel for phase 0 counties, which is the 5 in the sort of upper Willamette Valley, and limited travel in the counties that are in phase 1. Limited travel meaning staying in your local area as much as possible.
I wanted to interject here because there was another question we had got about whether Oregon has any travel restrictions in place. Some other states have some travel restrictions from other parts of the U.S. And the answer is no, we don't have any travel restrictions. When we do a case interview, we do ask about travel, but in terms of screening, we're not doing that. And, you know, it's not really as simple as, you know, have you been to New York or Detroit? It's really the hotspots we're seeing currently are sprinkled throughout the U.S., often small towns, places with, you know, meat packing plants, for example. And at this point, we kind of have to assume that there's some level of risk from any travel. So we're not having any kind of screening or restrictions for people traveling from specific parts of the country or the world at this point.
So this was in the context of some states having a 14-day quarantine, like Hawaii has a 14-day quarantine if you're coming in.
Right.
And then the last clinical question was, what is being done in long-term care facilities as far as testing? This is definitely a high priority for OHA for testing both patients and staff. And currently our guideline is that you should be testing people with symptoms liberally. And when the laboratories have sufficient capacity, people in long-term care facilities without symptoms could be considered for testing if there's a disease cluster or an outbreak that warrants it.
I would just add, I can't recall if you just stated this, Dr. Smith, but this is an area of ongoing focus, and anticipate that we'll have even updated guidance on this in the coming days or weeks. So we'll keep you posted if anything shifts in this area. All right, I'm going to look to my colleagues. Anything we missed today that you want to highlight before we close out?
Thank you again for all your great work and all of your care of Oregonians.
And keep sending us questions.
Yeah. We, of course, invite you again to join the Thursday Project Echo. Last week and this week again, there was an excellent expert speaker visiting our Project Echo. This week, I believe the focus is going to be on vaccine development. A tremendous amount of great information. I encourage you to take a look at the Project Echo slides from last week and join on Thursday if you can. This Project Echo, you'll see on the Project Echo website that there's a phase 2 for Project Echo starting in June. And there's significant benefit if you are to register for that, just in accessing information and CME. So I encourage you to take a look at the Project Echo website and join us on Thursdays for that, including this week, which should be a great one. Again, sharing my thanks for all of the work you're doing, and send us all your questions, and we'll look forward to talking to you Thursday again. Thanks. Bye.